afternoon. I'm Sherry Binns, the Patient Healthcare Liaison for the Multiple Sclerosis Foundation, also known as MS Focus. And our speaker today should be very familiar to all of you. Dr. Ben Thrower is the medical director of the Andrew C. Carlos MS Center in Atlanta, and he's also our senior medical advisor for MS Focus. Today he's talking about progressive forms of MS, and I know many of us are. I see a lot of questions about progressive MS and smoldering MS and things like that. So Dr. Thrower is going to address those things today. So Dr. Thrower, I'm going to let you put up your slides and take it away, and I'll go off camera till you're done.
Welcome, everybody, and thank you for joining us this afternoon. So, one of the things I think that's very frustrating for the MS community, because I know I hear it, I know Sherry hears it, is there's so much focus on relapsing forms of MS. Most of our FDA-approved disease-modifying therapies are approved for relapsing forms of MS. And so I wanted us to really take some time this afternoon and shift our focus to progressive forms of MS. When we think about progressive forms of MS, I would back up and say, well, what are the sort of the categories that we use, in sort of subtyping multiple sclerosis? When people present with their very first episode, a demyelinating event, we call that a clinically isolated syndrome. We have traditional relapsing remitting MS, where about 85% of people, present. And so over time, some people with relapsing remitting MS will evolve into secondary progressive MS. So it's really not like relapsing remitting and secondary progressive are different things. It's sort of a time spectrum, if you will. Hold that thought on secondary progressive, because we're going to come back to that and talk about some sort of further sort of divisions there. Primary progressive MS accounts for about 10% of the MS community. It doesn't play by some of the usual rules that we think of with MS. It is the one form of MS that is more common in men versus women. It tends to start a little bit later in life and tends to be much more of a spinal cord directed, injury versus a brain. It's not that they're not brain lesions, but it tends to be more spinal cord directed. Not a lot of active inflammation, and it just really gives primarily a lot of walking issues. Moving back to secondary progressive MS, we now subdivide that into with activity and without activity. I would argue that the without activity is what we've traditionally, most of us have thought of as secondary progressive MS. With activity would mean that you're still having relapses and or new lesions on MRI, sort of on top of that progression of disability. Without activity means you don't have new lesions on MRI or relapses. So when we talk about progressive MS today, we're going to sort of lump secondary progressive MS without activity and primary progressive MS. Where there has been research that focuses on one or the other, we'll talk a little bit about that. So what drives MS progression? There's been a lot of focus in the past on active inflammation. So active inflammation is the really obvious stuff. Either the person is having active relapses that then over years evolve into a progression of disability, or they have these big obvious new lesions on MRI. Sometimes these light up with the gadolinium dye that we've used. The newer concept, it's another type of inflammation, is this smoldering inflammation. And the analogy I would use, and sort of talking about active versus smoldering, is active inflammation would be a big forest fire. The smoldering inflammation is what's left behind after I put that big forest fire out. And now there are just these little embers underneath the surface that are still driving inflammation, but it's not big, obvious stuff. Loss of neural reserve, and we're going to spend some time talking about that, how that can contribute to progression of symptoms over time. And then deconditioning can also contribute. So what does MS do in the central nervous system? So we've always, talked about, active inflammation that causes damage to the myelin or the insulation of the nerve fibers. In 1998, there was the sort of the discovery. It was really a rediscovery, if you will, of axonal degeneration, or the wires being cut in the brain and spinal cord. A lot of our original focus in multiple sclerosis was on T cells. Our animal model for multiple sclerosis, the mouse EAE, or experimental allergic encephalomyelitis model, is really a T cell model, but we're really coming to understand how very important B cells are in this process. And some would argue that the B cells may be more important than the T cell driven inflammation. There is remyelination after the demyelination, so our brain can repair the damage to a certain degree. Why we don't do a better job of it as humans is an area of much research focus. We do know that the new myelin that is made tends to be thinner and is more prone to being re-injured over time. The concept of smoldering inflammation, again, newer concept. We think this is probably driven by a type of cell in the brain spinal cord called microglial cells. And this leads to this progression of disability without relapses or smoldering inflammation. The term that you'll hear used to describe that is an acronym PIRA, P-I-R-A, progression independent of relapse activity. We know that B cell follicles, so normally we think of the B cells as sort of living outside of the brain and spinal cord, making antibodies, coordinating immune responses that lead to inflammation, and that happening outside of the brain and spinal cord. But we know over time these B cells can set up shop actually in the central nervous system, especially around the covering of the brain and spinal cord, the meninges, and that this can drive that low level sort of chronic smoldering inflammation. Just one more word about microglia, because it's kind of been a hot topic in recent years. So microglial cells are cells that live within the brain and spinal cord. Normally, they're sort of like the CNS's garbage men, if you will. They clean up debris, and that's a good thing. So we normally think of good actions from microglial cells, but they can become bad guys as well. They can start contributing to this chronic smoldering inflammation. So when we again think of what drives progression in MS, the active inflammation, the obvious stuff, the smoldering stuff that's below the surface, and then the next thing that drives progression is neural reserve, or loss of neural reserve. Neural reserve is basically how much can I injure my brain or spinal cord, whether it's stroke, MS, traumatic injury, and I get away with it. So I have enough reserve, enough backup that, I've had an injury, but I'm not going to demonstrate physical symptoms from it. So as we age, we all lose neural reserve. That's just a normal part of human aging. So when you think about a person with multiple sclerosis who has these injuries in the brain or spinal cord, old MS lesions, as they lose neural reserve, those old lesions may become more problematic for them. So in that sort of scenario, the progression may not be driven so much by new MS stuff going on as much as it is driven by the loss of the brain and spinal cord's ability to adapt to those old lesions. And so the analogy that I've thrown out in the past that I stole from someone else is sort of the lake model. If you think of neural reserve as the water level in a lake, and old MS lesions, if you will, as tree stumps in that lake, if that tree stump is below the surface of the water, we may see it on MRI, but it's not giving you any obvious symptoms. If it's above the surface of the water, it's giving you symptoms. And now on top of that, you throw the lake level dropping with age. So in that scenario, if you will, so you have a tree stump that was, or an MS lesion that's giving you this much trouble, but as the lake level drops, now it's giving you more difficulty. The lesion didn't change. The lake level, the neural reserve is what changed. So, the challenge with that model is that current MS disease modifying therapies really don't change that lake level. They don't put water back in the lake. They help prevent new tree stumps from forming, which is awesome. They don't make the old tree stumps go away. And again, they don't change that lake level but that's again one of the other mechanisms we think that underlies the progression of disability. We're going to touch bases on that last driver of progression, deconditioning, as we move on a little bit. So putting this all together, what does this look like in your life, in the exam room at an MS center? Well, so you come in, you're an individual living with MS. What we typically see is that in this situation is there's progression of disability. A lot of times it's mobility issues, and the person has a stable MRI and they have no relapses. And I would say we see that, MS centers around the country, we see this every day, and it's frustrating for people living with MS and those that support them, for the healthcare provider to say, your MRI looks stable, there's no new stuff. Have you had a relapse recently? No, I haven't. But doc, I'm getting worse. And one of the messages we really want the MS community to hear is, we hear you, we believe you, we know it happens. So, as wonderful as a stable MRI is and no relapses, having no relapses, that's a great thing. We know it doesn't tell the whole story. So just thinking a little bit about, how we go about measuring progression of disability in MS. There are a lot of different tools that we use. We use things like the EDSS, Expanded Disability Status Scale. That's what the FDA for years accepted as the gold measure of disability measurement in MS. Not the most practical thing to do every time we see you. It takes a good 30 minutes or so to do an EDSS. There are some patient-reported versions of this, so you go online and you can actually sort of calculate what your EDSS would be based upon how you're doing symptomatically. And there's research showing that what you calculate your EDSS to be as a person living with MS actually correlates pretty well with what we would get in doing the actual exam itself. Timed 25-foot walk if the person is ambulatory. We try to collect this every visit in people with MS. 9-hole peg test to look at your upper extremity function. And the way we quickly screen for any sort of changes in cognition would be with the SDMT, symbol digit modality test. Takes just about 3 minutes to do. It's a great measure of processing speed. And there are some task force recommendations in the MS world recommending that people with MS probably should get that SDMT on an annual basis just to screen for any cognitive changes. Obviously, MRI has been a big part of how we monitor MS over time. There's things we've looked for on MRI. Usually it's any new stuff going on. We'll talk about in a moment how we might do better than just looking for new stuff. How you perceive that you're doing, your history, what you report going on. In research, we call these patient-reported outcomes, or PROs. They can be an important part of looking for progression of symptoms in people with MS. This is just a little blurb on what the EDS looks like, and I'm sure most of you are familiar with it. It's a scale that goes from 0 to 10. 0 is no disability, 10 is dead. 6, you're using a cane. 6.5, a bilateral assistive device like a walker. And at 7, you're using a wheelchair some of the time. It's very, very heavily weighted towards walking. There are some good things about EDSS. There's some bad things about EDSS, but it's just worth knowing because you'll see EDSS a lot discussed in MS research. So we're moving past just standard MRI where we look for new stuff. In research, we've been doing quantitative MRI for quite a while. Now it's really moving into the everyday clinic life in MS centers around the country. So using quantitative MRI, we're really trying to put numbers to things and be very objective about it. We are now sort of incorporating AI, or artificial intelligence, into this sort of algorithm. We want to be cautious about how we use AI in medicine. We want to make sure that we're using it in a sort of a thoughtful and controlled fashion. I think imaging is an area where AI can be especially helpful. Studies have shown that AI can sometimes see things that are not easily appreciated by just the human eye. One of those things would be slowly enlarging lesions. So if I look at your MRIs, it's sometimes hard for me to tell, is that lesion a little bit bigger than it was? We're pretty good at showing you, telling what you whether you have new lesions or not, telling whether a lesion's a little bigger, a little trickier. AI is pretty good at doing that. A deep part of the brain called the thalamus has a high correlate. Thalamic volume has a high correlation with how people with MS are doing, and some of these quantitative MRI programs are really great at doing this. What I put down here is what a report would look like for quantitative MRI. What we hope we're moving towards in the modern world of MS, and most of a lot of MS centers are now using electronic medical records. So Epic is the most commonly used one. What we would love to see is the day when we can take some of those earlier things we showed you, like the time 25-foot walk, the 9-hole peg test, your SDMT results, and then pick some of these metrics from quantitative MRI and show them graphically in your medical records so that we could look at 5 years worth of data in a quick snapshot. We're not quite there yet, but I do see a day coming when we'll have that sort of ability. So one of the other ways that we're measuring what's going on in the central nervous system and the person with MS is with neurofilament light chain. Neurofilament light chain is a protein that sort of helps make up the structure of neurons and axons within the central nervous system. It is released into the CSF and then ultimately into the blood, into the serum and plasma, where we can measure it when neurons and axons are damaged. So these levels of neurofilament light chain are a marker of neuronal damage. It's not specific to MS. We use it in MS, but it would also go up with, say, a stroke or traumatic brain injury. We also have to realize that the levels do change a little bit with age. So there are a lot of ways we're using neurofilament light chain now. We're using it to monitor how people are doing. We're using it to monitor how effective a therapy might be. We're using it when we're de-escalating therapy, when we're taking people off of treatment to say, okay, well, where was your neurofilament light chain level before you stop treatment, and what is it doing after we stop your treatment? We're making sure it's not creeping up for people. So shifting now to what therapies are out there. So where are we at now? What are some of the things that are on the horizon that we can actually do to hopefully prevent or slow progression of disability in progressive forms of MS? So we do have, really one FDA approved treatment option, and it is for primary progressive MS. So ocrelizumab, twice a year IV treatment. The Oratorio study was the study that showed that it did slow progression in primary progressive MS. There were two conflicting retrospective trials that have come out within a year of each other. So last October, there was a retrospective study. So this is where people go back and look at charts after the fact when someone's been on a given treatment. This October 2023 retrospective study confirmed that ocrelizumab did slow progression of disability in primary progressive MS. Just this month, there was another retrospective study that failed to show that. We always have to take retrospective studies with a little bit of caution, just because it's not a traditional prospective, double-blind, placebo-controlled trial. But we certainly want to put the data kind of into the big melting pot of how we think about a treatment in MS. So this is kind of old school going back. So glutarimer acetate, Copaxone, and now the generic versions of it, was a large 2007 study that looked at glutarimer acetate in primary progressive MS. And the conclusion was that they didn't see a treatment effect in primary progressive MS. There were concerns that the study may have been limited due to mild disease progression in both the glutarimer acetate group and in the placebo group. Great for the people in the study, their MS didn't progress very quickly. Bad for the study because it may have hindered the ability to see a difference between treatment and placebo. The other thing they saw in the study is there was a pretty high dropout rate for whatever reason. after the study was done, and this is true with a lot of studies, you can do something called a post hoc analysis. You go back and you say, well, let me look at the data. Then let me maybe look at just this group of people. What they did is they went back and they looked at the people who really had had more significant and rapid disease progression in the year prior to the study starting. It turned out that the people who were having more rapid progression were primarily the men in the study. So if you only looked at the men in the study, there was a treatment effect. And so there was slowing of progression if you just looked at that group. That sort of post hoc analysis is scientifically valid. It's not going to get you FDA approval, though. If you didn't design your trial that way from the start, you can do all the post hoc analysis you want, but the FDA is going to say, that's great. Go back and do another study just looking at men if you want. But that data is out there. So just within the past few weeks, this was at the ECTRIMS, or the European Committee on Treatment and Research meeting that was in Copenhagen this past September. They looked at an oral drug in a class of drugs called BTK inhibitors. BTK inhibitors have kind of been a hot topic in the MS world because there is a hope that maybe they address that smoldering inflammation that we talked about earlier, maybe in a way that none of our current disease-modifying therapies do. So tolebrutinib is an oral BTK inhibitor. The results from the Hercules phase 3 study in secondary progressive MS without activity were discussed back in September. And what they showed is that the 6-month mark, when you looked at the treatment group versus placebo, there was a 30% reduction in the progression of disability in the individuals on tolebrutinib. Maybe if we looked at people, so that's 6 months. I mean, we don't typically see drastic progression of disability in people with progressive forms of MS over 6 months. Usually we're talking longer periods of time. So it's promising that we saw that sort of reduction in that short of a period of time. So we'll, hopefully, as we watch these individuals longer, we'll see a greater reduction in the progression of disability. And, we certainly want to combine the treatment effect with whatever safety data we see. And hopefully this will represent a treatment option for secondary progressive MS that gets FDA approval in the near future. Frexalimab is a monoclonal antibody that's being studied in secondary progressive MS. This is a monthly IV treatment, a monoclonal antibody that works on a receptor called CD40. There was data from phase 2 study that was presented recently, and they used the biomarker that we discussed just a second ago, the neurofilament light chain, as a measure of neuronal degeneration. And what they showed is that there was a 41% reduction in that serum neurofilament light chain at 48 weeks in individuals with secondary progressive MS without activity. What we hope that correlates with is a clinical effect. It's great to make your lab tests look better, but we really want that to correlate with something meaningful in your life. So hopefully, as we get more results back, that lab biomarker finding will correlate with clinical slowing of progression of disability. Vidofludimus, we're participating in this study, a CALIPER study. This is an oral agent that appears to have both neuroprotective, anti-inflammatory, and antiviral properties. It's in a phase 3 study in both primary progressive and secondary progressive MS. There was data presented in September, again at the ECTRIMS meeting, and they also showed a reduction in the neurofilament light chain. 22% reduction. This was at 24 weeks. Again, so pretty quick evaluation. There more data will be coming out on the clinical effect. And again, we hope that lab finding matches up with an actual real world reduction in the progression of disability. So some things that are out there in testing right now. Avudilast is an oral agent that has been bouncing around for a couple of years now, has anti-inflammatory and neuroprotective properties. Studies in progressive MS have shown a slowing of loss of brain tissue or brain atrophy. And it seems to help prevent the slow enlargement of lesions on MRI as well. Again, more data coming in on that agent as well. Alpha lipoic acid is a supplement that has been looked at off and on. There was a 2018 study looking at 134 individuals with secondary progressive MS. And what they showed is that the alpha lipoic acid was associated with improvements in walking with some individuals. What the individuals who seemed to benefit the most were individuals who had less disability. So they had an EDSS of 6 or lower. So they were using a cane or better, is where you saw that primary treatment effect. Biotin is something that comes up periodically. Biotin, again, some over-the-counter supplement. Multiple studies have looked at this, the effect of high-dose biotin in MS. A lot of people use biotin to help with with hair, thickened hair or nails. This is a much larger dose than what you typically use just for hair or nails. 300 milligrams a day of oral biotin taken over 12 to 15 months has been associated with some improvement in time 25-foot walk. If this was something you were ever going to pursue, you definitely would want to coordinate that with your healthcare team. High doses of biotin have been associated with interference in certain lab tests. Troponin is something that's used in the emergency room to help doctors determine whether you've had a heart attack or not. And there have been some cases of heart attacks being missed because the biotin interfered with that troponin blood test. Can also a typo on hormones there, interfere with some hormone testing. So again, if it's something you're going to look at, make sure your healthcare team's aware of that. I'm not going to spend too much time here. So we did programs on this 2 months ago, and then we did an updated Q&A, another Q&A session. So you can go back and look at the MS Focus website for a whole program that we did on neural repair and neuroplasticity. But when we think about progressive forms of MS, we would love to stop the progression or slow the progression. We would also love to just reverse the disability altogether by either repairing or rerouting pathways in the brain and spinal cord. And then I'm going to finish up. I only did one slide on this, but really we could spend an hour talking just about exercise and rehabilitation for MS, especially progressive forms of MS. I think that this is something that gets overlooked. And when we think about making a person with MS function better right here and right now, I think that this is an area that we really need to spend some time with. Numerous studies have shown that exercise and rehabilitation can improve quality of life, mobility, mood, for people living with progressive forms of MS. In addition to working with a therapist or a trainer for physical therapy, rehabilitation, exercise, the other thing that physical therapists do a great job with is helping make sure you've got the right adaptive equipment, giving you the right tools to work with what MS is throwing at you. Study after study has shown if you look at a person with MS who's really struggling with walking or some other activity of daily living, the amount of energy that they expend to do a simple task like walking or say cooking or doing something around the house, is that energy expenditure is so much higher than a person not living with multiple sclerosis. So by getting you the right adaptive equipment, we may drastically improve your quality of life and decrease your fatigue that you're dealing with. And so with that, I am going to stop. This is farm property that we own in Athens, the two pictures, and then it's, even though we're not as fall-like as where Sherry lives, not quite as cool. We're kind of fall-like here in Georgia, so that's our two grandkids pumpkin picking this past weekend. And so with that, Sherry, I'm going to take my slides down and turn it over to you we'll have a discussion and Q&A.
Okay, your slides are still up.
Uh-oh. Stop that.
Just need to exit out.
That better?
Nope, you still have them up. There we go. You got it.
All right.
Okay, folks, most of you know the routine. If you have a question that you'd like me to ask Dr. Thrower, please put it into the Q&A and not into the chat. The chat is not for questions for Dr. Thrower, so um, do put those over there. Also, if you need to ask a question personally, raise your hand. I see we've already got one hand up right now. But I do want to, and we've got several questions in the chat, but I also, or in the Q&A, I'm sorry. I also want to, one person did put a question initially into the chat, and it's Jay, and he said, you said that primary progressive MS affects men more. I thought it primarily affected women.
The most forms of MS do affect women more than men by depending upon whose numbers you believe. It's about a 3-to-1 ratio of women to men with most forms of MS. Primary progressive MS is the exception, where we do see it affecting men more commonly than women.
Okay. Kathleen says, I was diagnosed last year with RRMS at age 71. How can that be differentiated from PPMS, which my mother lived with for 32 years after being diagnosed at age 52?
So when you look at MS within a family, so how one family member's MS behaves is in no way predictive of how the other family member's MS is going to act. So when we think about distinguishing relapsing remitting from primary progressive MS, a lot of that's going to be based upon the history of how you presented. So to make the diagnosis of relapsing remitting MS, you should have had a relapse. And so, with relapses, it's going to be, the relatively sudden onset, either days to a week of a new neurological event that you can say, I didn't have this, a week ago, and now I'm dealing with visual loss, weakness, sensory changes. Whereas with primary progressive MS, it's this very sort of insidious, kind of slow, sort of onset. I think one of the most typical things we see with primary progressive MS, it's the slow onset of walking difficulty. So imagine someone who, walks every day and they've had no difficulty last year, and this year they're saying, at a block now, I start getting a foot drop on the right. And next year it's a foot drop after a half a block, and now it's starting to affect the left leg. And so it's this kind of slow, kind of insidious onset of walking issues usually. MRI can be helpful to a certain degree. If we see someone that presenting with a lot of active lesions on brain MRI, that's pretty unusual for primary progressive MS. Not impossible, but unusual, and would maybe point you more towards a relapsing form of MS.
Kathleen does have her hand up. So, Kathleen, I've just allowed you to talk. So if you want to unmute yourself and ask your follow-up.
Okay. Yeah, I had a sudden onset of hemiplegia a year ago, June. I have not had any more relapses. They initially found a lesion in my cord, in my cervical cord, and not in my brain, but it turns out that my MRI was initially misread, and 6 months later, when I finally got to see an MS specialist, she was able to show me a single MS lesion in my brain. I haven't had another MRI since, and we'll be having one in a couple months. And I, the ironic thing for me is that I worked in spinal cord injury and MS care as a clinical nurse specialist for over 35 years, and this hitting me after retirement was not something that I expected. I thought when I got past my 50s, I would be out of the risk group of my mother, but that's not what turned out.
So thank you for all of your years of service, working with MS and spinal cord injury. Um, you know, we joke sometimes that as a healthcare provider, you're destined to get something weird as a healthcare problem. So that the way your symptoms presented with that sudden onset of hemiplegia would be a little unusual for primary progressive MS. I think the term that we would use for someone like yourself would be a clinically isolated syndrome. So you've had a demyelinating event. At this point, it's been a one-time event. So the question is, what is your risk for future events going forwards? Having even one suspicious looking lesion on brain MRI does put the person with a clinically isolated syndrome into a higher risk group for having future events. So depending upon how your MS specialist is looking at the data, so they could say, well, we're just going to watch you closely, and because you've only had one event, maybe we don't start any treatment, and God willing, you don't have any future events. That's always a tough question. Do you go ahead and be very preemptive and go ahead and start treatment? I mean, obviously your situation is a little unusual in that you've had your first event, as an older individual. But MS, everything with MS is trends, and nothing is absolute. We do see individuals like yourself whose your immune system just didn't read the textbook and didn't know that you weren't supposed to do this, after a certain age, but it does happen.
I was told that I had CIS initially until they found the second lesion.
Yeah, it gets kind of you start splitting hairs on kind of which label you use. That second lesion does carry a lot of weight.
Okay, we have Elizabeth has multiple questions in the Q&A, and she's got her hand up. So I'm going to I'm going to allow you to unmute Elizabeth and ask your questions.
Hi, thank you. Can you hear me?
Yes.
Ken.
Hi there.
Okay. So recently I saw a cardiologist who said that MS weakens the heart. And I understand if you are a sedentary person, and I have primary progressive MS, but I'm not sedentary. So what is it about MS that weakens the heart?
Yeah, I would disagree with that. I mean, there are some epidemiologic studies that would suggest people with MS might have a little higher risk of cardiovascular disease, the same cardiovascular disease that any of us could get. But in terms of it doesn't weaken the cardiac muscle itself. So yeah, I'm not sure quite unless they were referring to cardiovascular disease. So yeah, I mean, we encourage people with MS to be active. People with MS statistically die of the same things that the rest of the population dies from: heart disease, cancer, and stroke. But yeah, I don't like that statement that MS weakens the heart.
Thank you. I hadn't read that anywhere either. But also, I was wondering if medical marijuana taken orally or sublingually can cause any cardiovascular type side effects long term.
Not that I've seen. I mean, there's a lot of interest in medical cannabis. The literature on inhaled cannabis is kind of mixed, but on the orals, whether you're doing a candy, a gummy, an oil, doesn't, to my knowledge, I've not seen any data suggesting any cardiovascular risk factors there.
And my last question, I'm sorry, I may not be pronouncing this right. I believe it's fortulimab. It's the new nasal spray. And I think it works on remyelination. Can that be used in primary progressive MS when a person is not on any other DMT?
So, I mean, there's a lot of research on remyelination. That is, I mean, that's still in research right now. There wouldn't be, so when we think about remyelination strategies, I would think of those as kind of separate from disease modifying therapy strategies. So when you think about DMTs, your goal there, if it's a relapsing form of MS, would be to prevent relapses, to prevent new lesions on MRI, to prevent progression. When we're thinking about disease modifying therapies in progressive forms of MS, like ocrelizumab in primary progressive MS, really you're primarily focusing on preventing progression of disability. When you get into remyelination strategies, I think your goals are very different. You're asking more. You're wanting to push the clock backwards and reverse disability. So I think in progressive forms of MS, as we get treatment options for remyelination, I think it's very possible that people are going to be on some kind of neural repair or remyelinating strategy and not on potentially not on a DMT.
Thank you so much for your answers.
Absolutely.
Thank you. If you could just mute yourself again, Elizabeth. Kathy says, I was diagnosed with relapsing MS over 20 years ago at age 44. I haven't had a relapse in almost 20 years, but I still have progression. I want to keep taking medication at age 66. Is it necessary? I'm afraid that if I stop, it will get even worse.
So that discussion about de-escalation or taking people off of disease modifying therapies is another one of the hot topics in the MS world. I think one of the challenges for people like yourself is, so you've not had relapses for a while, you're on a disease modifying therapy. If we just looked at someone like yourself at face value and said, what label should we use? It would be tempting to use the secondary progressive label, but I would argue we have to be just a little bit cautious about that, because when we think about those labels, they really were designed to describe the natural history of MS. In a person on disease modifying therapy, we're not seeing the natural history of your MS. We're seeing some modified version of it. Could it be that if we took your disease modifying therapy away, that now we would see relapses and new lesions on MRI? And we really don't, we have some studies that have looked at the risks and benefits of stopping therapy, but I'm very cautious about pushing someone like yourself who says, listen, I don't want to stop therapy unless you can tell me with 100% confidence that I'm not going to have relapses or new lesions on MRI or more progression. I don't think we have the absolute answer to that. So I'm fine leaving people like yourself on a disease modifying therapy. I'll tell you just an anecdote from real life experience. Many years ago, when I started here at Shepherd, I inherited a lot of individuals on an older drug called cyclophosphamide or Cytoxan. It's an older chemotherapeutic type drug that has been used in MS. And some of these individuals sort of look like what you're describing yourself. They really had not had relapses for a while. And cyclophosphamide is not a drug that's free of side effects. So we had discussions, and with shared decision making, some of these individuals decided, yeah, I want to go ahead and stop this treatment and we'll see how I do. Most of these individuals did fine without it. We had a handful of individuals, though, who had not had relapses in a long time, that when we stopped their cyclophosphamide, bam, all of a sudden they start having relapses and new lesions on MRI. So I'm very humble about, saying I have a perfect crystal ball in terms of predicting how someone's going to do if we stop their therapy.
Thank you. Roxine has her hand up. I'm going to let you unmute yourself, Roxine, and ask your question.
Good afternoon. This is my first time joining. I've been diagnosed with multiple sclerosis, relapsing RMMS back in 2017. So I'm still learning and growing. Unfortunately, I'm trying to navigate resources for people with disabilities. Having MS, I deal with a lot of MS fatigue. And I just needed to know, is there any resources that MS Focus or any organizations are aware of for individuals who have disabilities because of MS diagnosis, for long-term disability insurance? I've been denied, and it's kind of hard navigating a denial and keeping a roof over my head. So I just wanted to know, um, I'm quite sure that there's millions of people that's been in a situation like mine, and I just wanted to know if there's anyone that could share resources, doctors.
welcome to the MS Focus. We're glad you're here. So talking to if where you're getting your MS care, if there is a case manager, that would be a wonderful place to start. Not all MS centers have case managers, but I would encourage you, if they do, sit down with that individual and talk about things like disability insurance, health insurance, life insurance, all those things. One of the very frustrating things with MS, and it's just really true with almost any chronic health condition, is the 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 likelihood that you can get private disability insurance is not great. Sadly, it's that those disability carriers, they want people who have almost no health issues. If a person with MS can find disability insurance, it may be pricey. The exception to that may be if your employer offers kind of a pooled disability insurance, like for instance here at Shepherd Center where I work, we can get in a sort of a supplemental disability policy that doesn't look at your health issues. It's kind of, because we're a big group, so it kind of covers everybody here regardless. So your disability insurance through a private employer might be one source. Other places you can look, and I'll certainly throw it open to Sherry too, because she's very knowledgeable. The National MS Society does have individuals called navigators that they've used in the past that sort of can help guide you through some of these issues that you have. Support groups, talking to other people with MS who have been down this path and are maybe a little further down the journey than you are right now, can be a great resource because they're living with it. They've gone through some of the challenges you're facing. Sherry, other resources you would recommend right off hand?
Certainly our webpage, msfocus.org. If you just go onto that webpage and search disability resources, there will be things that'll pop up in articles that have been written. Um, I've been at this myself for, well, knowing that I have MS for well over 30 years. And the resources are just not there. The resources are there to help us
Mm.
get our medications. They're not there to help us pay the bills for the most part. That said, we do have an emergency assistance program with the MS Foundation. You're more than welcome to start a dialogue with me on email, Roxine. It's Sherry, that's CHERIE, at msfocus.org, and we can maybe tailor it to what you need. Thank you.
Thank you so much. I look forward to that. And I'm actually in the capital of New York, Albany, New York, and that's where I'm located. And the fact that there isn't much support here in the capital district of New York is very disheartening. So I look forward to reaching out to you. I'm originally from New York City. I'm actually a state employee, and there really isn't much resources as far as I'm aware.
So as a
So
state employee, you should have that short-term disability at
they're the
least.
one they're the ones who denied me for long term. I
Yeah,
was approved for
but
short, denied
yeah,
for long.
That's so
yeah.
frustrating.
And once you get onto a disease modifying therapy and really get the process calmed down, you're going to see a difference. My guess is you'll be able to get back to work full time with no problem. And that's been my experience. Sometimes it takes a year or two to really calm it,
Yeah,
but so we've got a queue right now of
I'm
questions
sorry.
that are more than 40 questions. So, and I see several hands up. So folks with your hands up, please be patient. We're going to try to burn through some of these questions in the Q&A. And again, we are not answering any questions that are ticked into the chat. So, the Q&A only, and we've got enough that's going to keep us till the end of this hour. Christine asks if there's a test to see how much good or bad microglia someone has.
Yeah, good question. Not yet. So that we would love to have that, but yeah, not yet.
Okay. Angela says if remyelination is there but thin, Is this why we may see more worsening or progression in symptoms that we've had previously during times of stress, heat, or cold? If yes, then might this be why, outside of MS specialists, it's difficult to determine transition to a progressive form of MS, especially in the absence of new lesions?
Think the thin myelin, that the new myelin that's more prone to damage, is more what accounts for progression of disability. The heat sensitivity, the cold sensitivity, that you get stressed and symptoms act up. I think that's more due to what we call nerve fiber fatigue. So you have areas of demyelination. Those naked nerve fibers work, but they don't work as well as they did when they were myelinated. And if you stress the system, if you do repetitive exercise, important to remember, exercise isn't going to hurt you, but you can make symptoms act up a little bit if you push things too far. It's going to be temporary. If you raise your core body temperature, you can make those old areas of damage act up a little bit. I think we use the term barometer symptoms. I think most people with MS have what we call a barometer symptom, something that is unique to you, that is going to be your body, your MS telling you something's not right. It could be my vision gets wonky, my foot drops, something is going to say you're sleep deprived, you're stressed, you've got a viral infection. But so learn to listen to your body, because it'll usually tell you when the system's out of whack.
Thank you. Dave's got a lengthy question, but I'm going to try to shorten it. He was diagnosed 20 years ago with relapsing MS. His symptoms have continued to progress. He's EDSS has stayed right around 5, and he's wondering if it's possible to be secondary progressive right from the get-go.
So no, so we wouldn't. So secondary progressive MS by definition comes after relapsing remitting MS. If someone has a progressive form of MS from the get-go, that's primary progressive MS. So that said, there are people who go quickly from relapsing remitting into secondary progressive. It's not the norm, but yeah, secondary progressive MS always comes after relapsing remitting.
Janice wants to know, is it mandatory to have contrast every year with your MRI?
No, in fact, we're moving away from doing contrast routinely. You know, as MRIs have gotten better, we're finding that for a lot of people with MS, just for their routine monitoring MRIs, we see what we need to see without the contrast. Early in the diagnosis of MS, we might want to get, a year or two worth of scans with contrast just to establish a baseline. But I would say in 95% of our individuals with established MS, we are not doing contrast anymore.
Okay. Linda says, what age groups are found in the smoldering population? I'm 70. My therapies were stopped when I was 55. Disability has increased, but because of age and no obvious active lesions, it's considered not worth it to treat me.
So
And the next question, what can I do to be heard?
yeah, so that's frustrating. I think screaming, yelling, making sure that people know that you are getting worse, and then saying, what can I do about it? Smoldering MS just tends to be something we think of in people who've dealt with MS longer periods of time, but there is the thought that it may be present to a certain degree even early in MS. That's just sort of buried underneath that really active MS. So we may not appreciate it as much until people have been dealing with MS for a while. I think the challenge in individuals who've lived with MS for a while, when they're getting worse with no new MRI lesions, no relapses, is it loss of neural reserve or is it smoldering MS? One thing that might help with that would be the neurofilament light chain. If that serum neurofilament light chain by blood testing is going up more than we would expect for normal aging, that may be an indication that cells are still being damaged and that there's still something damaging them. Loss of neural reserve shouldn't still be damaging cells, whereas the smoldering inflammation would. Some of the newer MRI techniques where we're using volumetric studies, quantitative studies to look for slowly enlarging lesions would be the MRI correlate to that smoldering inflammation. So those would be the things that we would see. I think the last part of your question, the what do we do about it? That's the hard part. We don't know that our existing disease modifying therapies address that smoldering inflammation. there is the hope that these, some of the newer things like the tolobrutinib and other BTK inhibitors, that they do address it. So I think that's going to be something we have to watch very closely, and hopefully we get a BTK inhibitor, approved in the really near future, hopefully next year.
Okay, Susan's asking, why are MRIs needed when no other new drugs are available?
I think that's a fair question. It's a discussion to have with your healthcare team. Over time, if the person has had just stable MRI, stable MRI, stable MRI, could we back off? Could we maybe even start thinking about not doing them? As we get into better MRI techniques, like, looking for slowly enlarging lesions, maybe that would be the argument, that if we can do those better MRIs, maybe we should still get them to look for, for that sort of damage. If you're kind of realistic, you could say, well, if I see a slowly enlarging lesion right now, what am I going to do about it? If I'm already on a disease modifying therapy, or if you're saying none of the DMTs we have right now really address that smoldering inflammation, I think that's a fair question. And so that's a shared, the medical decision making discussion. We do have individuals that over time opt out of doing MRIs, that just say, I don't think it's changing what you're doing for me practically, and I get that.
Charles wants to know what your thoughts are on gold nanoparticles.
I mean, the idea of nanoparticles in healthcare, I think, is interesting. There have been some look at these gold nanoparticles in MS. Everything I've seen is really almost theoretical, and nothing that I would want to hang my hat on in terms of something I would recommend for a person with MS yet. I think it's a stay tuned kind of state of affairs right now. We'll see if that pans out to be something of clinical utility in MS. Right now, I think it's too early.
Thank you. Diane wants your thoughts on COVID's effect on MS.
I mean, any viral infection is not great for MS. So when you have a viral infection, it's not unusual for old symptoms to act up. We call those pseudo exacerbations. COVID is an especially weird virus, and some people, it seems to have had a lot more effect in the central nervous system. There were some reports of people having, new lesions on brain MRI. These are non-MS individuals with COVID infections. So I think that it's going to be highly individual as to how your body, responds to COVID. I think at a minimum, there's a chance people that have, temporary worsening of symptoms just because of the viral infection. I think there is the potential that in some individuals it may do more than that, that maybe we see longer term symptoms after COVID infections in people with MS.
Thank you. Judy wants to know if there's any association with progression of MS and brain tumors like gliomas or meningiomas.
So not even the glioma or any brain tumor is going to have its own effects in the central nervous system. That tumor is not going to interact directly with your multiple sclerosis. Where we do get into questions is what do the treatments for that tumor do to your MS? There is some evidence out there that radiation therapy, X-ray therapy for tumors of the brain may not always be great for MS. Unfortunately, with certain tumors, you've got to do what you've got to do to treat, what could be a life-threatening problem. So there's not really a direct correlation between the MS and the tumor, but we have to think about the treatments for the tumor, what that might do to your MS.
Okay. An anonymous attendee wants to know your thoughts about de-escalation therapy.
I mean, as we said earlier, big hot topic. As we get older, our immune systems do tend to calm down. It's called immune senescence. So there is the possibility that as we get older, that people may be able to come off of their disease modifying therapy. There was a trial, no, Sherry's really well aware of the DISCO MS trial. They looked at, there have been some studies looking at taking people off of Ocrevus, Gilenya, natalizumab, kind of your more highly efficacious therapies. You really have to sit down with your healthcare team and have that discussion about risks and benefits. We have taken a lot of people over the age of 60 off of therapy. Again, it's a shared decision that we have. We're using the serum neurofilament light chain in some of those individuals to look for anything sneaking up on them underneath the surface. So yeah, big hot topic.
Thank you. Bhavia, could you put Dr. Karpatkin's email address in the chat for Casey? She's having a hard time finding a PT who is familiar with MS. Um, Helen wants to know if pediatric MS progresses into primary progressive MS. She was diagnosed with PPMS, but think that it started around age 11.
Yeah, I mean, so we know when people are diagnosed with MS, it's not unusual that you go back and look at their life and there have been other things that have gone on, these prodromes. Uh, the studies have shown that the incidence of fatigue before an MS diagnosis is really high. People going to their primary care doctor for just very non-specific symptoms, way more primary care visits in people with MS before they're diagnosed. So there's clearly something leading up to the actual diagnosis of MS. So whether that event, at age 11, was part of the kind of the program is hard to say. And some people we go back and they clearly had an MS event, an optic neuritis or transverse myelitis, and it just was not really felt to be part of their MS picture. But in retrospect, we know that it was.
Teresa says, what if you've never had a remission, always in a flare? Is it PPMS? I was diagnosed with RRMS 13 years ago, and immediately I want to ask, what disease modifying therapy are you on?
Yeah. So I think the RRMS, that term is a little bit misleading, I think, at times, because remission, when we say remission, to me, that means I'm symptom free. And most people with MS are never symptom free. So even though a person may have relapse and remitting MS, they're usually going to have some symptoms in between relapses. So when you think about an MS relapse, some people don't recover completely from that relapse. So about 30% of people with MS do keep some permanent symptoms after each relapse. So, it is possible the person really has relapsing remitting MS, but they're just not coming back to baseline after each relapse.
What does your time look like, Dr. Thrower? We
Well, we
still
go,
have,
yeah, why don't we go another 10 minutes?
okay. Marlene wants to know, what about stem cells? I'm assuming since this is about progressive MS as related to progression.
So I would go back to the program we did 2 months ago on reversing disability. So we talk a lot about stem cells, both mesenchymal stem cells, which are primarily being looked at to repair damage and reverse disability, and then hematopoietic stem cell transplantation, which is, if you really look at it, is probably you would think of as a disease modifying sort of approach. It's just a really, really effective one. Most of the data with HSCT would argue that it probably is more effective in earlier relapsing forms of MS, but there is some data of HSCT in progressive forms of MS. But I would encourage people go back and look at that program from 2 months ago on reversing disability, and we go into that quite a bit.
Janice is asking, is UTI usually a trigger to getting a relapse?
So UTI is a trigger for a pseudo relapse or false exacerbation. So it's not that your symptoms are false, your symptoms are very real. When we have someone call in to our call center, and this is true with MS centers around the country, if you have worsened symptoms, new symptoms, the nurses are trained to ask you for signs and symptoms of an infection. And that infection, most of the time, is either going to be a UTI or a viral infection.
We've got several questions about MS. Exercise stopping progression. And as long as people are exercising, they say that they're not progressing.
So I'm a big believer in wellness and exercise for people with MS. We know that exercise keeps people from deconditioning. Exercise tends to improve how you function. Is it improving your function just physically, or is it actually doing something immunologically? There is some data out there showing that when people exercise, that they lower inflammatory cytokines in their immune system. So cytokines are just chemical messengers that our immune system uses. So there may be something more than just improving function and maintaining, wellness through exercise. It may be doing something immunologically.
We have several people asking questions about the association with viruses, particularly Epstein-Barr, with primary progressive or progressive forms of MS.
Yeah, so we know that viruses can be sort of that part of that environmental trigger to having MS. So MS results from both genetic factors and environmental factors. One of those environmental factors is viruses, and the most common virus that we think may play a role in a person's risk for MS is Epstein-Barr virus. Lots of research in the past few years looking at when people contract Epstein-Barr virus and what their risk of MS is afterwards. Um, what I think is a harder question is so Epstein-Barr virus lives in our body for life, and so does Epstein-Barr virus, reactivation play any role in what a person's MS is doing? I don't know that we know that for sure. One of the drugs we mentioned earlier, vidofludimus, oral agent that's in research, one of its mechanisms of action is antiviral, and there is a suspicion that maybe part of the way it works is by putting a lid on Epstein-Barr virus. So, yeah, Epstein-Barr virus is a really interesting virus, and I think we're just starting to scratch the surface of kind of the role it plays and what we might be able to do to intervene with that.
T says he's newly diagnosed at 63 with a relapsing MS. How important is it to see an MS specialist versus seeing his own general neurologist?
So I'm biased. I mean, I think when you go to an MS center, it's not just the MS specialist, it's the whole package. It's having access to research, case managers, physical therapists, occupational therapists, all of that. To me, in a perfect world, a person with MS would be treated at a comprehensive MS center. If that's not possible, I think the next best option would be to have a partnership between that MS center and your local neurologist. So maybe your local neurologist is doing most of your care, and you just touch bases with that comprehensive MS center maybe once a year to find out what's going on and research and see what other options are out there. I worry when someone says that one of those two, either the MS center or the community neurologist, doesn't like that. They don't want to play well with each other. There should be no egos involved in a person's medical care. Those two teams, they should be willing to really, work together to serve you, the person with MS.
Ampera made pre-existing conditions and essential tremor bad to the point that I could barely feed myself. Could you address that?
Yeah, so Ampera or dalfampridine, which is the generic, or 4-aminopyridine, which is the old compounded non-FDA approved version of that molecule, they all do the same thing. They improve electrical conduction in naked nerve fibers by working on potassium channels. What we hope they do is make your walking better, and they do in about 40% of people. What we don't want them to do is make old symptoms worse, and we do see that. Sometimes when you improve electrical conduction in a nerve, in a pathway, maybe you're improving electrical conduction in a pathway that you don't want to improve it in. The most common bad thing I've seen with the dalfampridine and pyridine would be either provoking seizures or worsening neuropathic pain. So someone has burning in their legs and you put them on Ampera and their burning gets worse. So yeah, so it does happen.
Ron is saying about COVID, do you feel that boosters should be continued?
I think that's a very personal decision. So you have to look at, what your immune status is, what your age is, what other health issues you might have, what people around you. Do you have, elderly relatives who might be vulnerable? And what is COVID itself doing? It is fortunately mutating to be less of a bad guy than it was back when we dealt with the Delta surge. People were dying and getting hospitalized pretty regularly with Delta, whereas we're seeing less of that now. But I would definitely sit down with your healthcare team and talk about the risks and benefits and see if you should continue it.
Okay. There are several questions in the Q&A on disease or on symptom management. Those would probably be better directed to me in the form of an email. Again, my email is Cherie, CHERIE, at msfocus.org, and we can tailor those questions to you. Diane says, is there such a thing as solitary sclerosis, and what is the prognosis?
So so with solitary sclerosis, I think what you would really be referring to is a clinically isolated syndrome. So the person has had one event, maybe optic neuritis, transverse myelitis, a solitary brain lesion. And so the people can have a one-time demyelinating event and never go on and do anything else. So they may still deal with residual symptoms from that one-time event, but they don't have any other events. And so, what tends to predict whether someone's going to have just a one-time event or multiple events is whether they have suspicious looking lesions on brain MRI or they have oligoclonal bands on spinal fluid or both. So I guess that would be kind of what she's referring to as a solitary sclerosis.
Mike says he's been diagnosed for 34 years with SPMS. Uh, for the last 4 years, no new lesions. Last MRI had 2 new lesions. His neuro has recommended a 1-year course only of Ocrevus. Is this a typical course of action?
So he would kind of fit into that secondary progressive MS with activity, which is it's kind of a fine line between that form of MS and relapsing remitting. It's kind of a gray area. So I would argue that he should be on a disease modifying therapy. Which one is going to be open to discussion between he and his team. So the idea of typically when we start a drug like Ocrevus, we're thinking about using it for a longer period of time. But there is this kind of question now with Ocrevus is does the person need to stay B cell depleted forever for the drug to work? Or is Ocrevus actually maybe reprogramming our immune system? Maybe it's making when the B cells come back, are they coming back less inflammatory? It's early research, but it's not a totally crazy idea to think about using Ocrevus for a shorter period of time and then seeing how you do. There's research looking at extended interval dosing Ocrevus, maybe rather than 6 months, going to every 9 months or every year. And there is some data out there to say that people are still getting a great treatment effect from that.
I think that takes us to the end of your time. And again, most of the questions remaining in the Q&A are symptom management related. I thank you so much for taking the extra time today. I know a lot of people like myself included are probably age-wise getting into that progressive state as well. And it's sometimes hard to tease age-related weakness or difficulties with progression of the MS. And personally, I think if my personal experience is the more activity that I get, the less progression there is. The cleaner I eat, the less progression there is. So there are things that you can do to sort of slow that. But again, let me know if you have questions related to that. Our next conference is going to be a week from today. It will start at 4 o'clock Eastern time. And it's the last of our Spanish language programs that for Hispanic month. It will be a panel of Spanish speaking individuals who are living with MS talking about their experiences. Thank you all so very much. Those of you that are on Zoom, please stay on the line for just a minute after we end the recording for a quick survey as to what we can provide for you that would be of help to you. And again, so many resources available on our website, msfocus.org. Thank you and be well.